Hi, my name is Danny Burford, and I am here with Dr. David Shelledy. Today's interview will be mainly about a resource that has recently launched titled Essentials of Mechanical Ventilation. Throughout this interview, Dr. Shelledy will be explaining what the resource is, how it can be used, and other important information regarding essentials of mechanical ventilation. To start us off, I wanted to give a brief introduction to who Dr. Shelledy is and the work that he's done. So Dr. David Shelledy is the author of Mechanical Ventilation and Respiratory Care, Patient Assessment, and Care Plan Development. Dr. Shelledy has served as a professor, respiratory care program director, and respiratory care academic department chairman for over 25 years. He's taught patient assessment both at the bedside and in the classroom to respiratory care students at St. Petersburg College, Georgia State University, Athens Technical College, Rush University, University of Arkansas for Mechanical Sciences, and the University of Texas Health Science Center at San Antonio. He currently holds appointment as professor and dean of school of health professions at the University of Texas Health Science Center, San Antonio, Texas. So thank you for joining me today. I'm very excited for this interview. And to get started, I just wanted to ask, what is the essentials of mechanical ventilation and what is included?
Well, Danny, thanks so much for meeting with me today. And I want to thank you and Jones and Bartlett for making this what I hope is a useful resource available to respiratory care clinicians and other clinicians caring for patients, particularly in light of the COVID-19 situation that we have in the U.S. and across the world. At any rate, this is a short, comprehensive guide of sort of the essentials, and it covers the evaluation and management of critically ill patients who require mechanical ventilatory support. It talks about some of the techniques and procedures for providing safe and effective mechanical ventilation. It's an online resource to provide clinicians essential information on a couple key things: when to start a patient on mechanical ventilation, how to initiate mechanical ventilation, and then how to adjust the ventilation to best meet the patient's needs and support the patient. And of course, the title of the resource is Essentials of Mechanical Ventilation. And it also includes a comprehensive slide deck. I mean, almost so much information, you're not going to believe it. 1,000 PowerPoint slides covering just about every commonly used ventilator in the United States and across the world. It includes a deck of the most common critical care ventilators, information about high-frequency ventilators, portable transport and non-invasive ventilators, as well as neonatal ventilators.
Wow, that sounds fantastic. So who is this product geared towards and who is it made for?
Well, it's geared to provide frontline clinicians caring for critically ill patients a comprehensive source for information about the indications for mechanical ventilation, ventilator initiation, and the appropriate adjustment of the ventilator based on clinical data and the patient's response. These materials are also hopefully going to be of great benefit to instructors and to students.
Fantastic. Why was this product created?
Well, the COVID-19 pandemic has just been something that none of us have ever seen before in our lifetimes. It's an enormous challenge, and it's an enormous challenge for the healthcare system and healthcare workers, particularly in areas where there's been a significant surge in critically ill patients. Many clinicians have been called to the front lines to care for these critically ill patients who may require mechanical ventilation. These resources should provide both experienced clinicians and those with less experience the tools to properly evaluate patients for possible ventilator commitment, as well as providing guidelines for ventilator initiation and adjustment. The slide deck also provides a great deal of detail on all of the commonly used critical care ventilators, as well as some other ventilators and equipment that might be pressed into service to care for COVID-19 patients.
How will this product assist those in the medical field?
Well, we hope this information is going to assist clinicians in the proper application of mechanical ventilatory support to critically ill patients, particularly those suffering from COVID-19 associated ARDS.
Okay, well, how do you see this product being used during COVID-19 and then the future?
Well, COVID-19 is basically an acute respiratory illness, and it might result in mild disease or moderate disease for some patients with no pneumonia or a mild pneumonia, which can often be managed conservatively at home and with isolation at home. But up to 20% of patients develop severe disease, and it's characterized by shortness of breath, dyspnea, hypoxemia, and often more than 50% of the lung is involved on imaging studies like chest X-ray or CT scan. And the patients may develop critical disease. So some subset of that 20% that winds up in the hospital winds up in the intensive care unit. And with critical disease, they have full-blown respiratory failure, shock, and possible multi-organ system failure. So patients with critical disease often develop severe hypoxemia and require admission to the ICU, oxygen therapy, and possible intubation and mechanical ventilation. And it's very important to understand, when do we intubate, when do we put a patient on a ventilator, and how do we do that? The major morbidity and mortality of COVID-19 is largely due to this acute viral pneumonitis that evolves into a full-blown acute respiratory distress syndrome, or ARDS. Mm-hmm. Now, COVID-19 presents some unique challenges for respiratory therapists and other respiratory care clinicians, and we all recognize that. However, I think it's very important that people understand that the sound physiologic principles, which have been developed over years for the ventilation of critically ill patients, still apply. Mm-hmm. Established principles of lung protective ventilation, techniques to improve oxygenation, and adjustment of the ventilator to meet the patient's needs are all very important in the care of COVID-19 patients. And these principles are reviewed and reinforced in the materials provided.
Mm-hmm. So why do you feel that this product is important in the era of the COVID-19 pandemic?
Well, particularly because mechanical ventilation is a very complex topic. And proper application of ventilatory support is a life-saving procedure, and it's highly valuable. However, improper application of mechanical ventilatory support can result in adverse patient outcomes, including death. Mm-hmm. Now, ideally, critically ill COVID-19 patients will have access to outstanding critical care respiratory therapists who've been doing this and are really good at it, critical care pulmonary doctors, critical care nursing staff, and the folks they need to provide safe and effective ventilatory support. Mm-hmm. Unfortunately, in the case of a significant surge in patients, there's not enough of those folks to go around. Right. And that requires evaluation and commitment to invasive ventilation. And other talented healthcare workers might be pressed into service. Mm-hmm. And these individuals should have resources available to them to learn current and up-to-date information about providing mechanical ventilation.
Right. I mean, that seems absolutely important. Do you think COVID-19 will affect the respiratory care field? And if so, how?
Well, I certainly do. The COVID-19 epidemic has made the general public and the media well aware of ventilators. I mean, everybody hears about ventilators and the need for ventilatory support in critically ill patients. Now, what this is doing is it's providing an opportunity to highlight the essential training and skills of the respiratory therapist and what they bring to the care of the critically ill patient. The respiratory therapist is the only one who receives intensive training on the operation of sophisticated critical care ventilators. And so it's almost certainly going to cause an increase in interest by prospective students in the field of respiratory care, and elevate the importance of the field in the minds of policymakers and providers.
Do you think COVID-19 will change the way mechanical ventilation is taught in the medical field?
Well, yes and no. As I mentioned, these fundamental principles, this physiologic fundamentals, are still absolutely in play and need to be front of mind for mechanical ventilation of the COVID patients. But undoubtedly, as we learn more about COVID-19, the application of mechanical ventilation to patients with the disease will continue to evolve. For example, it's not yet clear whether early intubation or application of non-invasive techniques is the best in which patient subtypes. Okay. For example, many COVID-19 critically ill patients do not develop hypercapnia. And hypercapnia is an elevation in CO2 with a decline in pH, and it's the classic indication for a ventilator. So without hypercapnia, should we put those patients on ventilators? And so that's important. And a conservative approach with those patients is simply to carefully monitor them. Begin oxygen therapy, typically with a nasal cannula in the range of 2 to 6 liters per minute, and then perhaps escalating the oxygen therapy using traditional tools like a simple oxygen mask, a partial rebreather, a non-rebreather. And then more and more folks are using a high-flow nasal cannula to enhance oxygenation and self-proning of the awake patient. And that is probably very appropriate in certain patient populations. However, the decision to intubate should be based always on sound physiologic principles and the known course of the disease. So the jury's still out in terms of best practices with respect to ancillary techniques such as proning in awake patients and the use of forms of oxygen therapy, as I mentioned, such as reservoir masks and high-flow nasal cannulas to avoid intubation. It's probably very reasonable to avoid intubation in patients with severe hypoxic respiratory failure without hypercapnia, particularly in younger patients without comorbidities. The high-frequency nasal cannula is probably preferable to non-invasive ventilation in these patients. But the decision to intubate should be based on sound principles, and those include things like how fast is the progression of the disease occurring? Are they getting real sick real fast? COVID patients can get essentially into complete failure in just a matter of a few hours. And so they have to be monitored very carefully. If there's not an improvement in oxygenation using a more conservative approach, like high flow, high oxygen concentration therapy, if there's an increase in CO2 levels, the development of hypercapnia, if there's a significant increase in work or breathing, or if there's deteriorating mental status, deteriorating hemodynamic status, and or multi-organ failure, then you probably need to intubate and get them on a ventilator. The other thing that I think is important, and it's one of the things that I felt was really helpful, I hope, for folks to get this particular information out, is we don't know a whole lot about the mortality, particularly in ventilated patients. Now, a severe case of COVID-19 evolves into full-blown ARDS. And in fact, some leaders in pulmonary medicine, and I call it COVID-associated ARDS, but they're calling it CARDS.
Gotcha.
Okay? But in traditional ARDS that we've been dealing with for many years, it's a bad disease, it's complex, but we've gotten the mortality down to about 35 to 46%. And there have been some papers with the mortality as low as 26 to 35%. Still not good, but a whole lot better than the chances of dying almost for sure if you need mechanical ventilation. But some of the reports coming out of New York have been very disturbing, with mortality rates of like 80% on ventilated patients.
Wow.
Okay. And it's not clear why that's happening, but it could very well be because the system is overwhelmed. And you've got folks pressed into service who perhaps are not as well trained and well experienced with the management of ARDS as the critical care pulmonologist and the critical care respiratory therapist. So I wanted to get this information out for them. The physiologic, while we've got a lot to learn about COVID-19, the physiologic principles of supporting oxygenation, ventilation, and circulation are the same.
Mm-hmm.
These principles are well known and taught by pulmonary critical care docs and respiratory therapists. But as I mentioned, many of the healthcare professionals, other healthcare professionals, have only limited understanding of the complexity of the modern critical care ventilator. So I'd expect to see a significant increase in the demand for instruction by respiratory therapists on how ventilators work and their proper application in patients requiring mechanical ventilatory support.
Wow. That's fantastic information. Thank you. What do you believe are the biggest takeaways from this product?
Well, as I mentioned, the mechanical ventilation is a pretty complicated subject.
Mm-hmm.
And it requires well-trained clinicians to properly apply ventilatory support to critically ill patients and achieve positive outcomes. COVID-19 is associated ARDS. It requires very skilled clinicians who understand the principles of oxygenation and ventilation and are able to apply these principles safely and effectively to save lives.
Mm-hmm.
And this provides a central role for the respiratory therapist. Misapplication of mechanical ventilation can be ineffective and it can be dangerous. And clinicians should be well aware of the proper application of the ventilator to critically ill patients. So these essential materials provide the minimum for making the decision to commit patients to mechanical ventilation, ventilator initiation, and patient stabilization.
Mm-hmm.
For those who are seeking additional information regarding critical respiratory care, respiratory failure, the principles of mechanical ventilation, detailed information on each ventilator currently on the market, and more detail on patient monitoring and assessment and ventilator weaning and discontinuance, might want to refer to the larger text.
Mm-hmm.
And the larger text is the one that you've already mentioned, and this is the text from which these materials were derived, and that's the text of Mechanical Ventilation by Shelledy and Peters. That particular reference also includes information about non-invasive ventilation, which is an option for COVID patients perhaps,
Mm-hmm.
high-frequency ventilation, which has some potential as a rescue, diagnostic and supported procedures in the ICU, including point-of-care ultrasound, and mechanical ventilation during ECMO. And ECMO, of course, is another rescue technique which might need to be kept as a last resort for the COVID patient. Now, there is tons of information available to the clinician. It's almost overwhelming, but I want you all to know on the website we have provided some links. The American Association for Respiratory Care has provided guidance. The Society for Critical Care Medicine have provided guidance, as well as there's been some outstanding papers in the Journal of the American Medical Association. NIH provides great guidance, and the Coalition for Baccalaureate and Graduate Respiratory Therapy Education have listed some preferred references. So all of those things are available to the clinician to help them to manage the COVID-19 critically ill patient.
Fantastic. I'll make sure that I highlight all of those links and make them available when we push this live. But I wanted to see if you had any final comments for us.
Well, Danny, again, thank you so much for having me here today. The bottom line is that in this era of the COVID-19 pandemic, mechanical ventilation can be a life-saving intervention when applied properly by skilled clinicians. And I'm delighted that Jones and Bartlett has made these detailed and up-to-date training materials available to the outstanding clinicians caring for critically ill patients in the ICUs and the emergency departments and in our hospitals. I hope these materials are useful for them as they seek to provide the very best care to their patients.
Mm-hmm.
Godspeed and stay safe.
Well, I really wanted to thank you for your time and for the wealth of knowledge that you shared over the course of this interview. So thank you so much.
Thank you, Danny.
All right.